Okay. Um, there is more in the dermatology chapter in the book than what we're covering this semester. So like you'll revisit this material for more of the chronic things like psoriasis, and some of the other more chronic skin conditions. We do a whole, we'll touch on eczema, but we do a whole module almost on atopic conditions in the summer. So we'll get really like more in the weeds in that in the summertime. So that we're not repeating information, just focus on what's in this, like the topics that are in this PowerPoint when you're studying. But review the tables that coordinate with this PowerPoint. So like the descriptions, there are good tables in there too, like which I didn't type. I mean, I put all the information in this PowerPoint, but not the tables themselves. But there's like how to differentiate all the bacterial rashes, how to differentiate the viral rashes as far as how they present, causative organisms, treatments. So I would study those like they give like brief information, but it's the big things, like the things that are going to show up in a question because those are the main points that help you differentiate them. So I would definitely study those tables. Okay. I won't read all of this to you. All of you know this stuff from health assessment and from being a nurse, but just understand kind of the layers of the skin because a lot of the skin conditions, especially like our eczemas and things like that, and some of the infections, they they occur and then get worse because of impairment in the skin. So if you can understand like the layers of the skin, it's easier to understand how you treat some of these things. We'll skip through this too. Um, Pigment, I do want to talk about a little bit about pigment lability. So, a lot of the skin conditions, even like viral rashes, have this post-inflammatory response, and they'll have either hypo or hyperpigmentation following the rash. That takes time to go away. So, I always like to tell parents that up front because otherwise they'll keep coming back. Like this rash isn't getting better, but it is. It's just the coloring, the pigmentation, especially in darker skin, is going to take time. So it can take up to like 6 months. And then if you have eczema on top of that, that they're constantly scratching, it's going to take even longer. So um, just know that even if the rash itself and whatever the disease process is that you're treating gets better, the coloring changes are going to take time to heal. Assessment, so kind of like Dr. Love was just saying, primary versus secondary lesions. This helps to break down what it is you're looking at to understand this. So primary lesions arise from normal skin. So um, like an impetigo, most of the time is primary because it just occurs in the skin. Now, if you have like eczema that's compromised the skin and then they get impetigo, that would be secondary. But the eczema is primary. So secondary are things that arise from changes in those primary skin lesions. When you're documenting skin stuff, you want to document the location and type of lesion, color changes, size, shape, arrangement. This also can help in. So I would understand these descriptors too, because this is a lot of times how things will be presented. Certain lesions are annular, and so you can immediately rule out some others in like an exam question if it describes an annular arrangement. Zoster form, that's almost always going to be shingles. So just understanding what these arrangements look like will help you as well. The pattern, so is it in an sun exposed area but nowhere else? Symmetry, things like that. And on the flip side of the sun exposed area, there are some things that primarily show up where in areas that are not exposed, like belt lines, the back of the neck, places like that. Distribution, borders, that is helpful, and then the consistency of the lesions. Darker skin tone variations. This is important because rashes, if you don't understand some of these rashes can be misdiagnosed in different skin tones. And they're not all the same. And I'm glad that our textbook finally has pictures of what most of these conditions look like in different skin tones because for a long time they didn't. And so you don't see that until you're in practice and it can be difficult to differentiate. But in these are variations for darker skin tones, and the darker the pigment is, um, the more differentiated that this can be. But erythema can be difficult to see because it's not going to show up like bright red like it will on, somebody who's very white. It can look more of like a purplish color. Some inflammatory disorders have a follicular pattern. Um, they do tend to have the darker the skin tone, the more significant that post-inflammatory response is. And again, it can be hypo or hyperpigmentation following really any type of rash. Um, they have a lower incidence of sunburn and chronic sun-induced diseases, but they still need sunscreen. And this is one that we hear a lot. Like they'll be like, "Oh, we don't need sunscreen. We don't burn." But like you can still get skin cancer. You can burn also, but you can get skin cancer and other sun-induced diseases. It's not as common, but it can happen. So everyone needs to be wearing sunscreen. Cafe au lait spots, we'll talk a lot more about this in theory 3 because we'll get more into our chronic neuro diseases. But if you see 6 or more cafe au lait spots on anybody, they should be referred to neurology because that's concerning for neurofibromatosis. Um, and they need to be evaluated for that. So even though they're more common in darker skin tones and it's not totally uncommon for them to have 6 or more and not have neurofibromatosis, we still refer them because they certainly could. Dermal melanocytosis is more common in African and Asian descents. Um, Physiologic changes that we tend to see with the darker skin tones, they have increased pigmentation in tongue and gums, pigmented streaks on the nails, and then void future lines. So this is where you can see like the demarcation along lateral edges that separate darker surfaces from lighter anterior surfaces. So the skin lesions, I'm not going to read all these words to you. These are in tables in the book as well. Um, but for some reason I put them all on here too. But macules are flat. So most of these, when you're studying, it just depends on how your brain works. I tend to group things like these are all similar, but one is flat, one is raised, one is, pustular. So I put them like in categories in my brain, but I didn't do that on here because I know everybody doesn't think that way. But like macules are flat, they're 1 centimeter or smaller. Patches are macules that are greater than 1 centimeter. So like in my head, they're the same. They're just one's bigger than the other, and that's how I differentiate them. Papules are solid, sharply circumscribed. They have very like distinct borders. They can be flat or raised a little bit, and they can vary in color a little bit, but they're like 1 centimeter or less. Whereas a nodule is pretty much the same thing as papule, but it's a little bit bigger. Um, Plaques are greater than 1 centimeter, so papule and plaque are pretty much the same. They look very similar, but the plaque is bigger. And then nodule and tumor go hand in hand. That really is based off of size as well. Purpura and ecchymosis, very similar. It's the bleeding underneath the skin. Hematoma, let's see, what are the other ones that are common? Vesicles. So a vesicle is the smaller, so it's a blister filled with clear fluid, but it's the smaller, and then a bulla is greater than 1 centimeter. So that's in a vesicle is less than 1 centimeter. So that's kind of how I think about them and group them. Wheals are evanescent, irregularly shaped, like more like urticarial lesions. Cysts are palpable lesions with definitive borders. Cysts can be filled, so cysts and papules can look similar, but cysts can have liquid or like even like a semi-solid material in them, whereas papules don't. They're solid. And then milia are white, small cysts. Remember from like, we typically see those in newborns. Secondary skin lesions. So these are all results of primary things that went wrong with a primary skin lesion. So scales, um, pustules. This is where usually a papule becomes infected or irritated and then fills with pus. And it's often on a hair follicle or a sweat pore. So some of our conditions like folliculitis that follow hair follicles, that's those would be pustules. Crusts are pustules or vesicles that have ruptured and then crust over. Let's see. Excoriation. This is where there's like abrasion or removal of the epidermis. It can happen from scratching. Pruritic rashes, it can also happen. Diaper rashes can get excoriated. We see a lot of excoriated diaper rashes. Scars and keloids can look similar. Keloids are usually more hypertrophied, so they're like thicker scar tissue. Lichenification, these are skin lines, and they have visible furrows, but they're thickening. They're usually like kind of rough in texture too, and it's from skin rubbing. We see this a lot with eczema, like chronic eczema, that hasn't been managed well. Over time, they can have some of this thickening of the skin. The big ones there. So these are the descriptive lesions, and most of these have to do with arrangement. So again, this is comes out of the book, but you can review these, and just a lot of these, if you know what these mean, it'll help you, because when you look at each of the individual rashes, they tend to follow certain patterns and they tend to look a certain way. And so if you understand what these are, then when you see a question that gives you a description, you'll have a better idea. Assessment. Obviously, we can do labs like CBC with diff, CRP and ESR. Those are helpful with like our inflammatory conditions, but they're not specific. So they can tell you if there's an inflammatory process going on, but they're not going to tell you specifically what that is. Skin scraping, so like a KOH, a potassium hydroxide. This is used commonly with fungal disorders. Most of our disorders, though, especially in primary care, we diagnose clinically. So you'll see like you can do a KOH for this, but most of the time you're going to see it just diagnosed and treated based off of the history and physical exam. For bacteria and viruses, there are different stains. Cultures we do frequently, especially for bacteria like abscesses and things like that. Patching and skin testing can be done, and then skin biopsy. I don't know of any pediatric primary care clinics that do skin biopsies, but I know some family practices do. So if you worked in one of those, you might do that. Or if you work in derm. Okay, so there's going to be some questions throughout, and most of them are after like the content. This one is just before, but that's okay. The primary care pediatric nurse practitioner is teaching a parent of a child with dry skin about hydrating the skin with bathing. What will the nurse practitioner include in teaching? Apply lubricating agents immediately after the bath. Soaping should be done at the beginning of the bath. Reduce bathing to once a week, or have the child soak in a cool water bath. You can just like blurt out your answers.
First one.
The
Apple.
first one.
Yep. So, when bathing, so they used to say, you'll hear people go back and forth on this, but the current recommendation is to actually bathe kids with eczema every day. And if they don't have skin conditions and they're not dirty, they don't necessarily have to take a bath every day, but especially if they have any type of skin conditions, eczema in particular, they should soak for like 15 to 20 minutes in lukewarm water every day. And then when you get them out, when their skin is still wet, not like soaking wet, but damp, that's when you hydrate the skin. And that's how it absorbs the best. Regular bathing. So we know kids with like eczema and compromised skin are more prone to secondary infections. And regular bathing can actually help keep those organisms off of their skin and prevent those infections. We do recommend doing the soap part of it at the end, like right before they get out, so that they're not sitting there like soaking in the soap, because that is irritating to their skin. So if they're gonna play, like do all that, let them play for a while first, and then do the soap and shampoo at the end. Management strategies. So avoiding irritants, wool, sweat, saliva, like that sounds so weird, but you'll see kids that like lick their lips and they get like dermatitis around their mouth from licking their lips. Fragrances is a big one. Laundry detergents, soaps, moisturizers, perfumes, especially in babies, perfumes that are on caregivers, or scented detergents that caregivers are wearing clothes that were washed in. All of that can really be irritating to their skin. And if they have eczema, fragrances on somebody else can irritate them. So a lot of times they'll be like, well, we're doing, Tide free and clear and all the things and um, fragrance free soap and thick like ointments and all of that, but they just are not getting better. And a lot of times it's because the caregivers are either still washing theirs in scented detergent or they're wearing perfumes or Bath and Body Works or whatever, and that'll break out the baby too or kids. So we talked about bathing. Baking soda or colloidal oatmeal baths can relieve the pruritus, and that's not just for eczema, that's for any type of like pruritic skin condition that they have. Baking soda is really good for diaper rashes too, but it is makes them very, very slippery. It makes the bathtub slippery and it makes the baby really slippery if you've ever given your kid a baking soda bath. Um, like I had heard that and like told people that, and then when I had a kid, I was like, oh wow, like very slippery. So I always tell people that so they don't drop their babies, but um very slippery. But it works really well for diaper rashes. It helps to with the pH. Heat exposure can make a rash seem worse temporarily. So when they're in the bath, the heat from that, or even if, they go outside and it's hot out, anything that makes them hot, it's going to make rashes typically look more red, more angry. But then when they cool off, it looks normal again. So when it will probably look worse straight out of the bath, but give it some time, it'll probably look better. We talked about using mild soaps, avoid bubble baths, bath bombs, all that kind of stuff. I don't feel like we see quite as much of it now as we did. Like a few years ago, little girls were like going crazy with the bath bomb kits and stuff. And it can be very irritating. So to really their entire body. So we don't recommend any of that. And then moisturizers, emollient based is the best. They're very thick and greasy, but it's what works the best to retain that water in the skin. Wet dressings. So these work well for acute conditions that have oozing, crusting, or are pruritic, and they help um, to dry the skin, even though it sounds counterproductive, decrease the itching and remove the crust. And we know like we need to remove the crust from impetigo before we apply a topical, or it's not going to really do anything. So we want these to be moist but not soaked. Leave them on for like 10 to 20 minutes a couple times a day for a few days. And then applying those topical medications after the wet dressings are absorbed, help them absorb more effectively. Occlusive dressings, these decrease water evaporation from the skin and enhance hydration. So like dyshydrotic eczema, psoriasis, some of the more chronic conditions that we'll talk about in another semester, um, are benefit from occlusive dressings. Sun protective agents, UVB rays do the most damage to skin and eyes. They cause premature skin aging, eye damage, cataracts, skin cancers, and immune system suppression. So even though some of these we don't think about happening in kids all that often, like skin cancer and cataracts, too much sun exposure and sunburning and things like that can actually suppress their immune system. Um, for 6 months and older, we recommend at least SPF 30, so 30 or higher daily. Um, Newborns and infants should be kept out of the sun. So we don't recommend using sunscreen under 6 months old. We also don't recommend that they're really in the sun under 6 months old. And for everyone, we recommend limiting sun exposure to limit their exposure to intense rays, use sunglasses, protective clothing, that type of stuff. If they can play, like in the middle of summer, if they can play outside either in the morning or later in the evening, that's ideal. And then sunscreen should be reapplied after swimming, excessive sweating, washing, or showering. Medications. So for acute inflammation, we can use those wet dressings, powders, because they'll help more with drying things out. Suspension lotions, alcohol or water-based lotions, aerosols, and foams. And then for chronic inflammation is more where we use like creams and oil-based things, ointments, more of the thick um, consistencies. And the tolerance and willingness to use certain types will vary depending on the person. The environment matters too, whether it's dry or humid. Eczema is the worst in really dry climates and really humid climates and does generally okay in the in between. But so that's why we see so much of it here because we're either really dry or really humid. We don't really have an extended period of time during the year where we're in between. So that's why we see a lot. We see a lot of eczema. All topicals except powders have enhanced absorption if they're applied after saturating the skin with water. So this goes into all of the topical medication preparations. Again, this came out of a table in the book, but I won't read all this to you, but these are all the different preparations that are out there for different things. We usually use creams, ointments, um, sometimes powders, lotions, and sometimes gels. Gels can be drying though, so there's not, with the exception of like acne, there's not a lot of things that we use gels for. Antibacterial medications. So there's bacteriostatic and bactericidal. Bacteriostatic inhibit the growth and replication of bacteria, and bactericidal actually kill the bacteria directly. When possible, or if something's not responding, that's when we do cultures. And if it's a more significant infection, it's not localized, or they have systemic symptoms, then we would do oral antibiotics. But for most skin stuff, we can do topicals. Antifungals, many of these are over the counter. We still tend to prescribe them um, because personally, I don't trust a lot of parents to go and get the over the counters and do them correctly. So I would rather just prescribe it and have the directions on it. Um, we use oral antifungals for fungal infections in the hair, nails, or like refractory infections that aren't responding to topicals. But we do want to use the oral ones with caution. They can have a lot of side effects, a lot of concerning side effects. So we don't do oral antifungals often. And there's not a lot of clinical experience in children. So even though we use some of them in kids, many of them are not actually FDA approved in kids. And they're used safe enough. There's just not a lot of trials that involve children. Antivirals, topicals help with like cutaneous herpes infections, and then the oral ones help to shorten the course of the infection. Um, Wart therapy destroys the keratinocytes. You'll see some wart therapy done in clinics. Most of the time, it's not all that effective. They just go away on their own, but there are different things you can do for warts. And then anti-inflammatory topical glucocorticoids are definitely the thing we use the most for anti-inflammatory. So like topical corticosteroids. The potencies range from high potency, class 1 to 2, to low, which is 4 to 7, and there's actually an 8. But the percentage, though, does not reflect the product's strength. It's the concentration of that particular medicine in that ointment or cream or whatever. So, like a hydrocortisone that's 2% and a triamcinolone that's 0.1% or something like that, that doesn't mean that the hydrocortisone is more potent. It just means it has a higher percentage, higher concentration of hydrocortisone in that ointment. Triamcinolone is still a more potent steroid. Ointments are more potent than creams. Creams are more potent than lotions, but foams tend to work better in hairy areas. The ointments and creams tend to just like stick to the hair, but I mean, we still use them frequently. For PCP, so in primary care, we always want to use the lowest potency available, use it sparingly, as short of a time as possible, and have them take breaks, especially if they're doing steroids long term on the skin, and especially if they have darker skin tones because it will discolor the skin over time. Um, Generally speaking, we don't really get out of the low potency area in primary care. You might see some every once in a while or refill something that dermatology started, but generally, if we get out of the low potencies and it's not working, we send them to dermatology. Um, On the face, buttocks, groin, and axillary areas, you only want to use low potency. Um, the face is a big one because a lot of our kids have eczema on their face, and so We might give them a stronger one to use everywhere else on their body, but you want to make sure you're using low potency on the face. Some of the side effects of long-term use: skin atrophy, striae, skin fragility, hypopigmentation. That is a big one, especially if they have a darker skin tone. Secondary infection, purpura, folliculitis. There's a lot of side effects to using them long term. And then oral anti-inflammatories in acute situations, not often at all. Do we use oral steroids for skin issues? So these are the ones. There's now, if you look at the table in the book, there are a lot more steroids, topical steroids listed. I would know these. The rest of them, dermatology pretty much prescribes. We don't usually prescribe them, so I wouldn't worry about knowing the rest of them that are there, but it is a resource if you ever need it. But these are the ones listed here are the ones I would focus on. Um, Class 1 to 2, those are going to be more of our chronic conditions. So we'll talk more about those in the summertime, but severe hand eczema is one where you may use like mometasone or something like that. Class 3 through 5, atopic dermatitis, nummular eczema, seborrheic dermatitis, tinea, if they have brief inflammation. That though, so per the book and per guidelines, you can do that for inflammation from tinea, but I wouldn't, and I don't, because steroids can make tinea, can make fungus worse. So a lot of times, if I'm even going back and forth between like, is this tinea or is it eczema, I'll give them both and tell them to like do the steroid, and if it gets worse, stop it and do the antifungal, because it will make tinea worse. But if you get the tinea cleared up and then they still have inflammation, then you can do the steroid. Um, and then sometimes after using a scabicide, because it can be really irritating. And then classes 6 through 7 are like our mild dermatitis, things like that. So that's where they fall class wise. You don't have to know like triamcinolone 0.025% is a class 7. Just know that like that's one that we would use. You wouldn't see a kid with eczema and immediately give them a mometasone. So that's really what you want to focus on. You would use hydrocortisone or and then triamcinolone if the hydrocortisone doesn't help. Um, and then Desinide, and then really like beyond that, you would send them to dermatology. Um, Antipruritic medications, topical antihistamines, we don't use these much at all. They can help with itching, but they can also cause burning and stinging. And a lot of times they're also using oral. So like if they have a pruritic rash, like say poison ivy, a lot of times they're using oral Benadryl and then they're doing topical Benadryl and then they're going to overdose on Benadryl. So we don't often recommend topical antihistamines. Oral antihistamines we're more likely to recommend, and they can help a lot with itching at night, because not so much that they help more than they do during the day, but they're sedating so they can sleep, because with the pruritic rashes, they can't. They often are up all night scratching. And then immunomodulators. These are not used under 2 years old, but they can be used for atopic dermatitis, and pruritus. Usually, though, these are going to be initiated by dermatology, and then you're just going to refill them or make sure they're using them correctly. But they don't cause atrophy or hypopigmentation, which is nice. Scabicides and pediculocides. These are toxic to mites and lice, so that's what we use them for. The ones that you'll mainly see used are spinosad and permethrin, and then there's also malathion, I think is how you say that. I've never used that, but permethrin is typically what you see used. You want to make sure you give precise instructions with these, because these are toxic. And so we don't want them just like, you'll get people in there like, yeah, we wash with permethrin every day, and like I don't know why we can't get rid of lice. We've been washing every day for 6 months. It's like, no, don't do that. Now you have super lice, and like a lot of toxic chemicals. So just make sure we're doing good education, and we'll talk about that when we get to head lice and scabies. And then for the hair and scalp, we use different shampoos. A lot of times medicated shampoos. And those are used for infection, psoriasis, dandruff, dermatitis, as well as sometimes some people use medicated shampoos just for their general use. Okay. So impetigo, I know we've covered this, so Non-bullous is honey-colored crust, superficial. Bullous is those larger blisters or bullae, and they continue to develop for days. It is very contagious. It is typically spread by auto-inoculation. So if you have a kid that continues to get impetigo over and over, um, or if they have impetigo and they have eczema, and we know that they're more prone to getting this repeatedly, you can have them put the mupirocin ointment on like a Q-tip and swirl it in both sides of their nose, and that will help kill. That's where most of the staph comes from that infects kids' skin because they, rub their face and pick their nose, and then it gets all over them. They cough, sneeze, and it spreads across their skin. So that's usually where the auto inoculation comes from in kids in particular. But it can also, be from poor hygiene, especially if it keeps spreading through a family over and over. Summer, humid climates, but it's very itchy and it spreads. Um, these descriptions, you've had that at the beginning of the semester. They can have regional lymphadenopathy, not always, but they can. So non-bullous is on the left and bullous is on the right. And this picture doesn't really have like the blisters and bullae themselves, but you can see where they were and that they ruptured and now they're crusted over. Whereas with non-bullous, they're much smaller areas and they have that honey colored crusting. That is pretty much always how a exam question will be worded regarding impetigo. It's either going to explicitly state bullous impetigo more than likely, or it's going to have honey colored crusting in the description, and that's if it says honey colored crusting, it's impetigo. Management topical antibiotics are preferred. So mupirocin 3 times a day is usually what is prescribed. That's first line. You do want to make sure that the crust is removed before applying it. Um, and because it's topical, it's treating where you put it. It's not treating any other lesions. So they need to put it on each lesion. Oral antibiotics, if they have multiple non-bullous lesions, or it's spreading or it hasn't responded to the topical, it's in multiple areas, if it's in multiple family members, or like sports teams, classes at daycare, things like that, then oral antibiotics would be indicated. Um, and bullous impetigo, you always do oral antibiotics as well. And you treat for 7 to 10 days. Um, Ideally, you want to use an antibiotic that's active against beta-lactamase producing strains of Staph aureus. So Keflex, Augmentin, those are the big ones. You can also use clindamycin for penicillin allergic patients. There is a growing resistance to clindamycin in our region specifically. So just know that you want a beta lactamase covering agent because they won't give you like you won't get a board exam question that gives you the options of Keflex, Augmentin. Like you wouldn't get these four as your options. You would get like Keflex or Augmentin, regular amoxicillin, just other antibiotics. You wouldn't get four that cover beta lactamase really well, because it differs by region. So more and more, we're seeing a lot of our bacterial stuff that the guidelines don't explicitly state like this one medication is first line because it does susceptibility varies by region. So just know that that's what you want to treat with is that the general antibiotics that treat beta lactamase. Um, if there's no response in 7 days, then you want to culture it. Um, Educate about, cleanliness, washing, cleaning the affected area with antibacterial soap twice a day, and making sure they clean out like the bathtub and things after they bathe so that it doesn't spread to everybody else. They do need to stay home until they are being treated for 24 hours. And if they're not getting better within 2 to 3 days, then they should come back and be seen again. Complications, it can definitely turn to cellulitis, and then staph scalded skin syndrome can also occur. It is rare, but it does happen. Um, and we talked about that education. So this is what staph scalded skin syndrome looks like. They literally look burnt. Okay, a preschool age child has honey crusted lesions on erythematous eroded skin around the nose and mouth with satellite lesions on the arms and legs. The child's parent has several similar lesions and reports that other children in the daycare have a similar rash. How will this be treated? Augmentin, 90 milligrams per kilo per day for 10 days, amoxicillin, um, 40, that should say 40 to 50 milligrams per kilo per day for 7 to 10 days, bacitracin cream applied to lesions for 10 to 14 days, or mupirocin ointment.
Me Pearson?
Yeah.
Okay. I questioned, and you just said you're going to question yourself. And I'm just...
So it's augmentin. And it's because it has spread. So it's not just around the nose and mouth. They have satellite lesions as well. And they have other children at daycare with a similar rash. So those were some of those indications for doing oral antibiotics. If it's in multiple locations, family members also have it, daycare class has it, athletes, like their teammates have it, you would want to do oral medication for that. Okay, cellulitis. This is usually Staph aureus or group A strep, so your antibiotic choice, you can narrow things down that way. The chronic skin conditions like eczema puts them at risk for cellulitis because they have that impaired skin barrier. They can have fever, irritability, vomiting, chills, decreased appetite, all that kind of stuff, but a lot of times they don't. A lot of times it's just the cellulitis. They often will have a recent sore throat or a URI, and if you think about the organisms that cause it, that makes sense. On physical exam, there's this erythematous area that's indurated, tender, swollen, and warm, but it doesn't have well demarcated borders. It's not like an abscess that's pretty well demarcated. It's more of like a generalized area that's really red, swollen, tender, and warm. Buccal cellulitis often appears with a blue to purple tinge. They can have regional lymphadenopathy with cellulitis. Let's see. So most of the time, again, like everything else in skin, we usually just treat empirically, but you can do labs, and you want to do a CBC and blood culture if they're febrile with it, they appear like really ill and toxic, or they're under a year old. On a CBC, you would see leukocytosis and then gram staining culture. So if you suspect something that is not, like if their history or their presentation is not consistent with it being one of the more common strains, if you do suspect something unusual, and they have pus that you're able to culture, then you do want to do that, or if they look toxic. They need immediate antibiotic therapy. If it's an infant or like a febrile infant, or if it's a neonate, if they look really ill and toxic, or for any like facial and periorbital cellulitis, we do send them to the hospital. If they're under 3 months, they get a full septic workup. But starting them on antibiotic therapy as soon as possible is very helpful. Using a medication that covers group A strep and Staph aureus is usually going to cover you. If there is a concern about high community rates, then make sure that you use something that covers against MRSA in your region. For us, tends to be Bactrim or clindamycin, and it kind of goes back and forth on which one works better at the time. But Keflex, Augmentin, those are going to be your big ones for bacterial skin infections when you're using oral antibiotics. So that's typically what you would go to first. And then if they become toxic at all, they need to go at any point, or it's getting worse instead of better, then they should go to the hospital. They should follow up in 24 hours because you want to make sure that it's not getting worse. In those first 24 hours, it's probably not going to make a huge improvement, but it shouldn't be continuing to get worse, especially rapidly. Complications, they can get post-streptococcal infections, septicemia, necrotizing fasciitis, and toxic shock syndrome. So we want to make sure that they are really cleaning the skin well, especially anytime there's a break in the skin. Keep bites, scrapes, rashes, all of those things clean and bandaged, covered up until they're healed. Frequent hand washing. we tend to see this more in the summer because of all the insect bites that get infected. Age flu can cause this, so it is helpful if they are vaccinated. And then perianal spread can spread through shared bathwater, so making sure they clean the bathtub well. That is what necrotizing fasciitis looks like, and then toxic shock syndrome. So they get they get the rash um, that spreads really across the whole body, but they get like really bloodshot eyes. A child is brought to clinic with several bright red lesions on the buttocks. The primary care pediatric nurse practitioner examines the lesions and notes sharp margins and an orange peel look and feel. The child is afebrile and does not appear toxic. What is the course of treatment for these lesions? Empiric antibiotic therapy and follow-up in 24 hours. Hospitalize the child for IV antibiotics and possible IND. Perform gram stain and culture of the lesions before initiating antibiotics or obtain blood cultures prior to beginning antibiotics.
I will say the first one.
Yeah.
I was gonna say hospitalized.
Yeah, it's the first one. And it was on that slide. I didn't say, I kind of skipped over it.
Oh, I
But
didn't see that.
it was on the slide. Um, and so I'm not gonna say this right, but erysipelas, just no orange peel. Orange peel. Description is a variant of cellulitis. So if you see that, know that it is likely cellulitis, and you would do antibiotic therapy and then follow up to assess them because they don't appear ill, they're not febrile, they're not a young infant, so they're stable.
I have a question. Like I've seen in clinical practice, do they use bank a lot for like cellulitis as well?
In the hospital, they will. I haven't seen it used a lot in primary care, but that's not to say that it wouldn't be used. Yeah. They will cover it, but usually they'll do that like IV in the hospital.
I have seen Rocephin used for cellulitis, but it was periorbital. It was my son.
Yeah, yeah,
That's been some time ago. It's been some time.
yeah. And there are so like Rocephin is similar to Keflex. Um, as far as like recommendations, we always try to do the oral antibiotics if we can first, but there are situations where you will see Rocephin used like if it's if they've been on other antibiotics recently, or like kids that have severe developmental delays or autism that are really not going to take the oral antibiotics well, they're going to spit most of them out. Sometimes it's more beneficial to just do Rocephin because you know that they're getting it. So there are times, but just generally speaking, um, this is what's recommended.
So if they did come back for a follow-up and they like weren't responding to antibiotics, would you just immediately like send them to our like you would bypass cultures and all that jazz and just
Yeah, a lot of times you can't, there's not much to culture with cellulitis.
Mhm.
Um, because there's not really like an abscess there that you can
Right?
get to. So yeah, if they come back in 24 hours and it's not worse, but it's like about the same, that's good because it's not getting worse. So then I
Hmm.
would just see them back again in like another 24 hours and see if it's improving. But if they're getting worse at any point, like it's continuing to spread or they're starting to have systemic symptoms, then yeah, they should
Okay.
go to the ER. Um, all right, folliculitis, furuncles, and carbuncles. These are all put together because they're all essentially the same. They just are variants of each other. Folliculitis is bacterial inflammation of the hair follicle. So this is where like looking at whenever somebody has a skin issue, looking at the entire body and looking really closely, like getting really personal, shining your light on it, like really looking close because some of these will look like other things, but then you're like, oh, like these are clearly on hair follicles. Then it helps you to differentiate what it is. Furuncles, these are abscesses. So beyond just that inflammation, these are bigger abscesses involving the hair follicle. And then carbuncles are like crops of furuncles. That's like groups of them, multiple together. Um, Usually this is staph. Hot tub folliculitis is Pseudomonas. Um, and we do see that, the hot tub folliculitis. I don't know why it grosses me out more than the others, but it just does. Um, on history, it's pretty itchy, like it's pruritic, and then the furuncles tend to be tender. Um, so sometimes this will start as folliculitis and then turn into like a furuncle, or they'll have like a more widespread folliculitis and then have one area with a furuncle. So usually it starts out itchy because it starts out as the folliculitis, and then the furuncles are actually painful, but it makes sense because it's an abscess. Um, Hot tub exposure, if they have a rash and hot tub exposure, like it's probably hot tub folliculitis. And then sometimes they can have some systemic symptoms, but not always, and not most commonly. On physical exam, these are really small, red 1 to 2 millimeter papules, or they can be pustules they look like little, like it almost looks like acne, but it's on the base of the hair follicle. Face, scalp, extremities, buttocks, back, really everywhere. And then furuncles are nodules with larger areas of erythema and tenderness, and they're usually not as widespread. Like you're usually not going to have furuncles as widespread as you do folliculitis. Um, and then pruritic papules, pustules, or deep red to purple nodules that are most dense in areas that are covered by a swimsuit within a few days of being in a hot tub, probably hot tub folliculitis. Um, and then again, systemic symptoms are not common. They can be seen, but they're not very common. You can do a gram staining culture, but usually this is diagnosed and treated clinically. So this is what hot tub folliculitis looks like, and you can't really see the hair in this picture, but it's on the hair follicles. So management, warm compresses after washing with soap and water several times a day. They really need to keep their skin really clean. Um, they can do like benzoyl peroxide, chlorhexidine, or bleach baths a couple times a week. And then topical keratolytics. So benzoyl peroxide, 5% or 10% twice a day for 5 days, especially if they get this repeatedly, which sometimes they will, especially like teams like football teams early in the season when it's still like really hot and humid out, and if they're sharing pads and stuff, they'll all start coming in. Like they'll trickle in over the course of a week. More and more will come in because it's just spreading through the equipment. Um, and so if it's recurrent or chronic, then you want to do that. Fluctuant lesions should be incised and drained. So like a furuncle, if you're able to, you want to drain it. And a lot of times that's sufficient. So if you don't have like a widespread folliculitis and you really just have like an abscess, like one furuncle, you can usually do an IND and that's it. They don't need antibiotics. It usually heals after that, and it feels a lot better once that pressure is released. Um, but if they, you know, I usually give mupirocin anyways, but per guidelines, it can heal on its own. But for bacterial lesions, if it's superficial, you want to do topical antibiotic like mupirocin or topical clindamycin twice a day for 2 weeks. And then anti-staphylococcal beta-lactamase antibiotics. So Keflex, Augmentin, dicloxacillin, if it's severe or if it's widespread. Usually by the time they come in for a folliculitis, it's pretty widespread, and we do oral antibiotics. I don't feel like it's super common to give a topical for folliculitis because it's usually a larger area at that point. Whereas like a furuncle, commonly they'll come in with just one or two of them. For hot tub folliculitis, it's generally self-limiting as long as they're healthy. Um, if it's severe, then they'll need oral quinolone. We don't prescribe that often. It has a lot of side effects. So usually keep the area clean multiple times a day. They can do those keratolytics, and then usually they don't need anything else. And then keeping their hot tub well maintained, or like not using hotel hot tubs because they're probably not well maintained. I always tell people too, I learned this in nursing school when the health department came for some reason and talked to us about stuff. And you guys probably know this, but the stronger the chlorine smell, the dirtier the water. Because the smell from the chlorine is from it actually being like used and activated and killing things. So when you go to like a hotel or a gym and it smells like really strong of chlorine, it's probably gross. And you would think the opposite, but I always tell people that because, they're in those hotel pools. Um, Review personal hygiene habits, avoid shaving until it's resolved. That's a big one, especially with girls, because they're going to use that razor and they're just going to keep doing it and keep getting folliculitis. So avoid shaving until it's resolved. Follow-up treatment in 1 week for folliculitis, 1 day for a furuncular abscess, just to make sure that they are getting better, nothing's getting worse. Complications, deeper abscesses, and then carbuncles, of course, like spreading to having crops of them. So good personal hygiene, antibacterial soap, and then again, usually hot tub folliculitis self-resolves, but it can recur for a few months. An adolescent who recently spent time in a hot tub while on vacation has discrete erythematous 1 to 2 millimeter papules that are centered around hair follicles on the thighs, upper arms, and buttocks. How will the primary care PMP manage this condition? Order an anti-staphylococcal beta-lactamase resistant antibiotic, hospitalize for IND and IV antibiotics, prescribe topical keratolytics and topical antibiotics, or culture the lesions and treat with IM antibiotics.
C, the third one, right?
Yep. So the topical keratolytics, usually it self-resolves, but they can do topical antibiotics if needed. Paronychia, it can be chronic. A lot of times it's acute, but it's inflammation and infection around a fingernail or toenail. And a lot of times we'll see them come in with these and they always think this is an ingrown nail. Like every paronychia, I feel like presents with like the chief complaint is an ingrown toenail. But then it's not always an ingrown toenail, it's just infected, but ingrown toenails can get paronychia. And it's actually funny. When I was doing this, I was sitting on my couch, like putting the pictures in this. And my husband was like, "Is that an ingrown toenail?" I was like, "No, it's not. That's actually, I'm gonna be sure to say that because that is what everybody thinks." Um, Causative agent, it can be bacterial, it can be fungal, it can be viral, usually herpes. But it's more common with tight shoes or when like nails are misaligned, cut too short, or they round like the edges on their nails, and so then they start growing underneath. They're very tender. A lot of times they're leaking drainage and they're really uncomfortable, especially when walking. So you'll see like a lot of redness, swelling, really tender, and then if you are able to express it, you'll get purulent exudate out of it. A lot of times the cuticles are damaged, and with Candida, they'll often have non-tender. So if it doesn't hurt that bad, or it's like thickened or scaling and peeling, it's probably Candida and not bacteria. You want to culture the exudate if at all possible. You want to drain it because that's what it feels better. Usually, if you can drain it and express that exudate out of it, they feel a whole lot better. And then you can treat it from there. But you want to culture that drainage. Herpetic whitlows and eczema are differentials. So that's what it looks like. Frequent warm soaks and then sticking cotton underneath. So if it's a nail issue where it is growing underneath, then you want to stick cotton up underneath it to help lift it out so it doesn't keep growing downward. For acute infection, we do oral antibiotics, so coverage for staff. As a good rule of thumb, I mean, Keflex, Augmentin, clindamycin, Bactrim. Those are really your big ones that we'll use for most of these bacterial skin conditions. If it is Candida, antifungals rarely help. So you can do the topical corticosteroids to help the inflammation and allow for that tissue repair, but usually it will respond on its own. But we can, you can treat it like athlete's foot, which we'll talk about in a minute when we get to tinea. But Candida doesn't usually respond to antifungals, especially topical, the same way in that area that tinea does. If purulent exudate is present, you want to loosen the cuticle and allow the exudate to escape. If it's recurrent, then send them to podiatry because they probably need to have something more invasive done. And then do a 1 month follow-up visit because it is possible and often likely that they're going to have a recurrent infection. Complications would be like cellulitis, deeper infection, things like that, chronic paronychia. So we want to educate on all those things that are risk factors. So wearing wide-toed shoes while it's infected, if they can wear open-toed shoes, that's ideal. Trim the nails straight across, don't cut them too short, and then good hand hygiene and things like that. Um, Candidiasis, so we're gonna switch into fungal infections. And you've probably been seeing this in clinical, at least diaper candidiasis, like we see a lot of it. Antibiotics, steroids, or inhaled corticosteroids recently are big risk factors for this. And a lot of people will know, like, especially females, like adolescent females, like every time I take an antibiotic, I get a yeast infection. So a lot of times we'll just prescribe an antifungal at the same time. Same thing with diaper rashes, like babies and toddlers with chronic ear infections. Their parents a lot of times will be like, can we just get some nystatin too because we know it's coming. So that's fine because we know that it is definitely correlated with antibiotics and steroids. So they get a rash in a moist, warm area. The diaper area is a common one, but really like any skin folds, creases, those are common places too. The neck is a really common place in infants, especially in the summertime. It's often pruritic. A maternal yeast infection when breastfeeding an infant can go to the infant and vice versa. If the infant has thrush, they can give it to mom too. So in the mouth, they have these adherent white plaques. It kind of looks like cottage cheese, and it's on their mucous membrane, so it can be on lips. If it's on the lips, it's called cheilitis, but the corners of the mouth, it can be like all inside the mouth. And when you go to, so it can look similar to milk sometimes, but when you scrape it with a tongue depressor, it won't come off. Milk will come off. Inner trigo is in the skin folds. Diaper area, this is usually like moist and like really beefy red, dark red macules and papules, and they usually have pretty well demarcated borders. And then they can have satellite lesions and erosions. The vulvovaginal area, they get like a thick, cheesy yellow discharge, erythema, edema, and itching. Balanitis, this is where, like on the penis itself, they get erythema and scaly patches. They can also have papules and vesicles. And then on the nail plates, kind of like we were talking about with paronychia, it'll cause transverse ridging of the nail plate. So if you see nails with transverse ridging or cuticle damage, it's probably fungal.
Hey Kelly, on back just to back on the mouth
Mhm.
when the inhaled corticosteroid, I'm remembering this from nursing school, so tell me if it still applies or not. They should be doing when they use the inhaled corticosteroids, they should be doing some kind of mouth rinsing
Yeah.
after.
Yeah, they should. They should either drink some water or rinse their mouth out and spit it out. Yep. And wash, which when we talk about asthma in depth this summer, we'll go into that more, but washing all of it, like the chamber, the mouthpieces, all of that should be washed like at least weekly too. You can usually tell it starts looking nasty and you're like, oh, yep, gotta wash that. KOH scrapings can be done, but again, most of the time these are diagnosed clinically. Um, so management varies by location. And hang on, I'm gonna go forward for just a second. Okay, yeah. I separated these out by, okay, so management, there'll be a picture and like the management on each slide going forward. Did this really late at night. I couldn't remember if I did it that way or not. So patient and family education, good hand washing, frequent diaper changes, leaving the diaper area open to air as much as possible. So if they're just at home, like let them be without a diaper, laying on a towel on the floor or something. They can blow dry with warm air to help dry quicker. Avoid rubber pants. I don't know. This has always been like a recommendation, but I don't know who's out wearing rubber pants. I guess I don't know. I don't know who's wearing rubber pants. Um, Use mild soap and water, all of those things. Powder can help to maintain dryness, but we really don't often recommend powder, so I don't even talk about that unless we're prescribing nystatin powder, because people get crazy with like the Johnson and Johnson powder. And then discard or sterilize pacifiers.
I
So
actually think they still sell those rubber, those waterproof pants for the diapers. I actually still think they're sold.
I guess that's what they're talking about. That is crazy.
Uh, uh,
Cloth diapering is like too far for me. Rubber pants is just crazy. Oral nystatin suspension is what we use for thrush. So they do it 4 times a day, and then you want to go a couple days after the white patches are gone. So they're gonna put it in the mouth, coat the surfaces of the mouth that are affected, 4 times a day until it's gone, and then an additional couple days. If they're breastfeeding, the mother should also put it on the nipples to eliminate reinfection. And then a second course is sometimes needed, especially if they're breastfeeding. They tend to pass it back and forth a couple times. If it is resistant to treatment, we can do oral fluconazole. There just are a lot of side effects with oral antifungals, so we really try not to if we can get away with it. Once whatever they're using for the medication, like dropper, syringe, whatever, once anything enters the mouth with thrush, it cannot go back in the medicine bottle or the nystatin is no longer good. So if they like suck on the syringe and then they stick it back in now the whole bottle of nystatin is bad. So it's not going to clear it up. So that is something you really always want to tell them. If they're little, like infants and young infants especially, I usually tell them to put some in like a medicine cup and then use Q-tips and like soak it and rub it on the surfaces. And then, because you can use as many as you need to and like as many sides of a Q-tip without sticking things back in the medicine. And they can't swish anyway, so that way you're coating all the surfaces you need to. But they can just, squirt it in their mouth if they want to. It's just, you can coat the surfaces better that way if they're too young to swish. Cutaneous candida, we use topical antifungals. So usually it's nystatin, but you can use these other ones as well. And it's applied with every diaper change or like 4 times a day, if it's somewhere else on the body until the rash is gone, and then a couple more days. Um, you want to avoid antifungals and corticosteroid combination medications because corticosteroids can make fungus worse. Really anything that likes sugar is going to go crazy with a corticosteroid. So that's why like diabetes, they tend to have spikes in DK and things if they're on steroids. Fungus like sugar, so anything with a corticosteroid is going to make that worse. If inflammation is severe, then you can do hydrocortisone as well with the nystatin or whatever you're using, to the diaper area for a couple days. And then you want to keep it cool and dry and all the things we already talked about. If they develop a secondary infection like an impetigo or a cellulitis, then you would treat with antibiotics. But this in and of itself won't respond to an antibiotic. It might actually get worse. But the neck is a pretty common place to see it in babies, especially if they're, have more rolls or they're like drooling a lot and it just sits in there and then they grow yeast. And that's what it looks like. And this is a candidiasis diaper rash. All right, an infant is brought to the clinic with bright erythema in the neck and flexural folds after recent treatment with antibiotics for otitis media. What is the treatment? Oral fluconazole, topical nystatin, topical keratolytics, or nystatin with hydrocortisone.
The second one? No.
Yeah. Topical
Yeah.
nystatin cream. Yep. And so that's a candidal infection, like that picture was just showing in the neck. And you would just do the topical nystatin. That's first line therapy for that. You wouldn't want to do the steroid because it can potentially make it worse. And then you wouldn't need to do oral or anything like that yet.
What would an occlusive dressing look like to
That
go
was
over
my
that?
next question.
Yeah,
Yeah.
with an infant, because I was
Yeah.
like, oh, is it?
Yeah, so you can use if it's somewhere where you can like wrap it, you can use like plastic wrap. But like a neck, I definitely would not like wrap plastic wrap around. So just like the clear bandages, that have like a border, but the middle of it is open. Um, that's what I would put on it. Or
You
you
might be able
do
to
like plastic
find like
wrap, put medical tape around the outside of it, like around the border on it. But I wouldn't wrap. Yeah, I wouldn't wrap their neck.
I was gonna say you might be able to find like Mepilex like stuff, but in Walgreens.
Yep, yep. Okay. Tinea. Also fungal. Tinea will usually see hair loss if it's on the head. It generally is pruritic and it can look very similar to eczema, especially early on. And usually they'll have contact with another person with it, or cats and sandboxes are like big vectors for tinea. So if they have like cats, if the cat lives inside it or like is a pet, it's usually not a big deal. But if it's an outside cat or like a barn cat, they can get ringworm from this very easily. And sandboxes are like, and like all the kids love sandboxes. I'm always like, no, if I see a sandbox, we're not staying. We're going the other way. Because it is a common place to get tinea. So they'll have scaling, erythema, and crusting of the lesions. If it's on the scalp, there will often have bald patches or area of broken hairs. You'll literally see like the hair is broken off. Um, and then they can also have black dot tinea. So it's like lots of little black dots where the remainder of that hair has like broken off at the shaft. Um, let's see. So tinea is one, when they have it on the head, they often will have lymphadenopathy, not always, but they can. And then a carrion is a boggy, this is something that they like to test over. A carrion is a boggy, inflamed mass filled with pustules. It results from, it's a delayed inflammatory reaction to something. Often it's tinea. So often after they've had tinea on their scalp, this inflammatory reaction happens and they get these, it's pretty gross looking. I'll show you a picture in a minute, but they're like the first time you ever see one, it is very alarming. And it looks really bad, but it is a carrion and the contents are actually sterile. So you don't do antibiotics for it, even though it looks like you want to do antibiotics for it. Um, it will clear up on its own. It will rupture and it will heal over, but unless they have systemic symptoms with it, you wouldn't treat it. So this is all how tinea can look in different people, but the bottom right picture is what carrions look like, and it like it's hard to like ignore. Like we're just gonna leave this alone because it looks really bad, but it's actually sterile. Like if you culture the contents, it's sterile. Um, Tinea tends to, the first question I always ask if they have a tinea on their scalp is like, where do they get their hair cut? Do they use clippers and how recently? Because it tends to come from barbershops, on boys especially. Clinical diagnosis is usually done, but you can do Woods Light or KOH, or like a fungal culture. So Griseofulvin for tinea capitis is what we use. We don't use topicals on the scalp. They're not going to do anything. I hate seeing tinea capitis because it is so long. It is so much medicine. Like when you dose it, it is a large volume and they have to take it for 6 to 8 weeks. Or for at least 2 weeks after it's gone. So sometimes it goes beyond the 6 to 8 weeks. They need to take it with fatty food, so that can be even like whole milk. But they need to take it with fatty food. That's what helps it absorb. Um, you'll see terbinafine used more and more frequently in kids over 4. Griseofulvin is still what's in the guidelines, so that's what we recommend. But clinically speaking, not test speaking, clinically speaking, you can use the other. Fluconazole is approved, but it has been shown to be less effective, so I would use that as a last resort. If they have a long-standing carry-on, you can do prednisone for a couple weeks, but again, that's an inflammation response. It's not an infection, so you wouldn't do an antibiotic, and normally we wouldn't do prednisone either, because this started with a fungal infection. So like we don't want to keep going in a cycle of developing fungus again because we took steroids. And if though they do get a secondary bacterial infection, you can do antibiotics, of course, but just standard carry on, you don't do antibiotics. Asymptomatic carriers can be common, so consider culturing family members or pets if this is a recurrent issue. And then you want to schedule follow-ups after 2 weeks to evaluate their response to treatment. Monitoring CBC, liver function tests, and renal function is no longer required with oral greaseal fulvin. But if they are on it longer than 8 weeks, then I would check those. It can be really hard on the liver. So it used to be recommended that we check labs before and periodically during treatment, and that's no longer recommended. But if they're going to be on it longer than 8 weeks, then I personally would check labs. Complications. So an interface dermatitis or ID reaction to the fungus, and it's a reaction to the fungus, not the medication. They get a red superficial edema or like scaly red plaques and papules on the scalp. Treated within 1 to 2 weeks of topical or systemic steroids. And then again, they can have permanent hair loss and scarring if carry on develops. So ideally, we identify the source of infection and treat the source or avoid the source. Side effects of medication should be explained. Photosensitivity is the big one. They can also have headache. They can have some skin eruptions. We'll talk about Stevens-Johnson's this afternoon, but usually it's going to be those GI disturbances, but it's helped if they eat the fatty foods with it. Hair regrowth is slow. That's important to make sure they understand. This is not just going to like grow back immediately when the medication is done. It shouldn't keep spreading and it should be improving, but the hair itself is going to take a long time to grow back. If there's a carry-on, the hair loss may be permanent. We want to make sure they wash sheets, clothes, everything in hot water, and then use a hot dryer cycle to help keep it from spreading. And then, of course, talk about grooming practices and that it can spread easily. Tinea corporis or ringworm. This is localized, and so systemic symptoms are usually, we don't see those with this, but there is usually contact with a person or animal with tinea. Again, the sandboxes and the cats are common. The classical appearance of lesions is annular, oval, or circinate with one or more flat, scaling, mildly erythematous circular patches or plaques, and they have red, scaly borders. So this is where like knowing the descriptions of the lesions is important, because if you have an annular lesion with a scaly border and central clearing, it's tinea. Like unless there's something very obvious in the question that tells you it's something else, it's tinea. Central clearing, gonna pretty much always be tinea, but especially if it's annular and has scaly borders. So lesions spread peripherally and they clear centrally. So they have like a pale center and then they have a very well demarcated red scaly border. They can start out as pustules, so they may look like folliculitis initially and then, or like just even like a little pimple, but then it develops into a tinea lesion. And they can spread as well. And that's what they look like. And I like that this is one of the things that I really like that they have started putting different skin tones, because this version of the book, the one that we even used last year didn't, and it's frustrating because you can see it does not look the same. It has the scaling borders and things like that, but I cannot tell you how many kids I've seen who've gone to like urgent cares or other places who treated by people who typically see adults, but they have tinea and they've been treated with a steroid. So then it's out of control. Like they've been diagnosing this eczema and treating it as eczema because you can't see the redness like you can on lighter skin. And so understanding the differences is important so that we're treating them correctly. You can do, again, KOH scrapings, fungal cultures, but usually you don't have to. So usually if it's superficial and it's localized, and normally it is, we do topical antifungals. So miconazole or clotrimazole are usually what we use, and you want to apply it to the lesion, including a zone of normal skin. So you want to go outside of the borders of the lesion itself and do that twice a day until the lesions are cleared, and it can take like a month. So it's just important that they understand that. On the face, so like tinea faciae, and that's like when it's in like beards, like in the skin within a beard and facial hair. They often need oral medication like Reseal Fulvin because it's because of the hair. And then extensive infection, immunosuppression, other tinea infections on the scalp or nails, or if it's unresponsive to topical treatment, then you would do Greaseofulvin and follow all the same stuff that you do for capitis. They can get tinea incognito, and they can also get that ID hypersensitivity response as a complication. So again, eliminating the source, treating any contacts, and then educating about like hygiene, how it spreads, all of those things. They do need to stay home until they have been treated for 24 hours. And follow up in 2 weeks to make sure that it's not still spreading, or sooner if it's not responding. Tinea cruris, this is jock itch. We tend to see this in the hotter, more humid months, tight clothing. Athletes is a lot of times who we see this in, but it can be in anybody. And oftentimes this goes along with tinea pedis. So a lot of times we'll see this along with athlete's foot. But they have more of a raised border with scaling pustules or vesicles. They can have central clearing. It's usually bilateral and symmetric, but not always. So if it's unilateral, doesn't mean it's not this, but it just is generally speaking bilateral. And it can spread outward. Usually we diagnose this clinically. The management is the same as tinea corporis, but usually requires a little bit longer treatment, like 4 to 6 weeks to clear up. Again, avoid steroids. It'll make it worse, most likely. And making sure that they are practicing good hygiene practices, washing their clothes really well, wearing looser fit clothing is helpful. Talcum powder or antifungal powder can be helpful. I've never recommended talcum powder to anybody, but antifungal powder you could do. It often spreads similarly to other forms of tinea, so locker rooms and things like that. Athlete's foot is tinea pedis, sweaty feet, non-breathable shoes, nylon socks, exposures. So like at home, if someone has it and they're taking showers in the same shower, or in locker rooms, walking around barefoot and things like that. But this is more of an intense, it can itch, but it's more of an intense burning and stinging, and it can have a really foul odor. And then they get micro trauma. So they'll have cracks, abrasions, cuts on the feet, like scaling and peeling. It's really common in damp areas. And so they'll have red, scaly, cracked rash on their feet. And we'll look at a picture in just a minute. Sometimes it spreads to the dorsum of the foot, but usually it's not. It's often in between the toes, but that's what it looks like. So management is the same as tinea corporis. And you want to go, again, outside of the borders of the rash twice daily until it has been cleared for 7 days. And this one is usually 3 to 6 weeks of treatment. Rarely do you need to use Greaseofulvin, but if it's recurrent or if it's not clearing up after 6 to 8 weeks, then you can do Greaseofulvin for 6 to 8 weeks. Complications are the same as the others. And so the education is really the same too, keeping the feet dry, avoiding areas where it's commonly spread, rinsing their feet with water or water and vinegar after being in places where it could potentially be exposed, or once they are already infected, washing their shoes, not wearing socks more than once without washing them, all of that kind of stuff. And then they follow up in 2 to 3 weeks or sooner if it's not responding.
Hey, Kelly, on the bleach, I know you said bleach bath. I caught it earlier. You're like a maybe a cup full of bleach for a tub of water?
Yeah,
I'm
it's
just making sure I understand.
It's I'll find the exact instructions, but it's 2 tablespoons. Yeah.
Okay.
Yeah, it's
Okay.
not a lot. Mhm. A school-age child has several annular lesions on the abdomen characterized by central clearing with scaly red borders. What is the first step in managing this condition? Perform KOH-treated scrapings of the lesion borders, obtain fungal cultures, prescribe antifungal corticosteroid cream, or treat empirically with antifungal cream.
D.
Yeah. Yep.
Yep.
This is a classic tinea corporis. And so you would just start with antifungal cream. All right, onychomycosis is fungal infection of the nail, commonly toenails, but it can be any nails. But they usually will have like a thickened, discolored nail. It usually doesn't bother them other than the appearance of it. Um, and again, toenails are more involved than fingernails with tinea. And tinea is more commonly what we see, but candidal infections are more common in infants. And then fingernails are more involved than toenails, and that's usually because they're sucking on their fingers and putting them in their mouth. Um, that's what it looks like. So topical treatment with cyclopyrox can provide a cure in most patients, but it can only be used in 12 and older. So in the little ones, cannot be used. Oral medication is more successful based on the data. So itraconazole for 12 weeks, which is just crazy. The oral antifungals, they have to take them for so long, um, is typically what is used, and they have lower recurrence rates. Terbinafine and fluconazole can also be used. They just generally don't have the same resolution time, that they take longer. But we do want to follow up at 1 month intervals for LFTs because they're taking these medications and it's really hard on their liver. Um, and then long-term follow-up every 6 months because it can be recurrent. It's difficult to obtain like a real cure for this. Relapse is common. A lot of times we'll send them to podiatry if this is recurrent, just to have them take a look at it. But it tends to be a recurrent condition. And once they are treated, shoes should be discarded that have been exposed to it, or treated really well with disinfectants and antifungal powders. Tinea versicolor or pityriasis. So you usually won't hear it called pityriasis versicolor outside of the ICD-10. That's how it's in there. You'll usually either hear people say tinea versicolor or pityriasis, but there's another pityriasis. So usually we call it tinea versicolor because it gets confusing. But just know coding wise, when you're entering codes for this, it is coded in ICD-10 as pityriasis versicolor. We usually see this in warm, humid weather. We see quite a bit of this here in the summertime, but they have multiple annular. They can be scaling, not always. Macules or patches, and they can be hypopigmented, usually in darker skinned individuals, and hyperpigmented in lighter skinned individuals. But it's usually on the neck, shoulders, upper back, arms, chest, areas that are commonly exposed to the sun in the summertime. And they tend to have a raindrop pattern. So if you see a raindrop pattern in the description, it is probably tinea versicolor. If you do a KOH, it'll have spaghetti and meatballs appearance, which is gross, but we usually don't do that. Dermatology will sometimes. The treatment for it is selenium sulfide, 2.5% lotion or 1% shampoo. This is over the counter. It's Selsun Blue shampoo, or I think Neutrogena makes one too, but I usually just tell people to get Selsun Blue, or you can prescribe it. But you put it in a thin layer. And you want to go several hand widths beyond the lesions. Like I usually just say wash your body in it for 10 minutes and then rinse it off. And you do this for 1 to 2 weeks. And then after 2 weeks, go to monthly applications for 3 months because this does also tend to be recurrent. Older adolescents can use ketoconazole shampoo once a day for 3 days, but the younger kids cannot. Topical antifungal creams can be affected, but because it's such a large area that's being treated, it's not usually recommended. And then you want to make sure you follow up in a month. This is another one that's important to tell them. If it's not spreading and it's not flaking when you scrape the skin, then it's working. The treatment is working because the pigmentation is going to take time to heal. That's going to take several months. That's not going to go away in the 2 weeks of treatment. So if it's not continuing to spread and there's no flaking when you scrape the skin, then it's doing its job. Sun exposure makes this more obvious. So people have this all year. We just tend to see it more in the summer because they're exposed to the sun. It really makes the pigment changes stand out. and really obvious. So that's usually that's part of why it's usually widespread when we start treating it, is because they've had it for a little while, but you just couldn't really see it. So this is what it looks like in different skin tones. The top one is like, that's clearly fungal. You can tell that that's fungal, but usually what versicolor will look like is the second two pictures. So in the lighter skin, it's more of that hypopigmentation, and then in darker skin, it's areas of hyperpigmentation. A child is diagnosed with tinea versicolor. What is the correct management of this disorder? Ketoconazole shampoo, sun exposure for up to 1 hour every day, oral antifungal treatment, or application of selenium sulfide lotion.
It's the last one. It's
The last one?
application of selenium.
Yeah. Yeah, it's the last one. And that can be used in all ages. So if it doesn't give a specific age, selenium sulfide is the first line treatment anyways, but if it doesn't give a specific age, assume that they're not over 12 years old, because it doesn't say that they are, and go with selenium sulfide. Anything that is age specific like that, if it doesn't give you an age, go with the one that is good for everybody. Okay, viral infections. These I'm gonna really like go through quickly because we did cover these, and you can read about these. It goes into them in depth in the book, but the viral stuff we just don't do a whole lot for. So I'm not gonna read descriptions and stuff to you. You can read. But we'll hit the high points on these. So herpes simplex, we have HSV1, HSV2. HSV1 is more of like the skin lesions, generally speaking, like the gingivostomatitis, the lesions in the mouth. Herpes labialis is the lesions like around the mouth. Cold sores, like the classic cold sores. Herpetic whitlows, these are on fingers, and they look like painful vesicles or bullae, like on the distal part of the finger. And it's a lot of times kids who suck on their fingers, they have the HSV in their mouth and then it gets on their finger. And cutaneous, so that can be anywhere on the body. It's often misdiagnosed as impetigo or herpes zoster, shingles. But it's always erythematous. They may or may not have vesicles with HSV lesions, but there's always erythema. And then HSV2 is usually the genital version. It can be in other areas, but it is, for all intents and purposes, it's in the genital areas. Viral cultures are a gold standard. You won't see that done all the time because it is easy to diagnose clinically in most cases, but as far as diagnostic studies go, the gold standard is a viral culture. So herpes labialis is the one on the left. That's like a classic cold sore. And then herpetic gingivostomatitis is on the right. It's really painful, the gingivostomatitis. The herpes labialis is usually, they'll say it's like tingling or stinging, especially before the lesion pops up. They'll have like itching around their mouth and tingling, and then they'll wake up with a cold sore. But inside the mouth, this is what it looks like. And this is one, remember, that stays dormant. So it stays dormant in the body, and then when the body's under stress, for whatever reason, they're sick or life happens, that's usually when this flares up. That's a herpetic whitlow. And then on the right is cutaneous herpes. Management. So for cold sores and lesions inside the mouth, they usually just clear up on their own. Topical antiviral creams have not shown to be real effective, but if they're over 12 years old, you can do acyclovir for 4 days. You want to start it when symptoms start. If they're over 2, you can do oral antivirals. And the time frames are here, from 2 to 11, acyclovir for 5 to 10 days, and then 12 and up, they can do valcyclovir or acyclovir. If this is recurrent, especially frequently recurrent, then I would treat them with acyclovir. Routinely, we don't treat HSV like all the time, but for sure, if it's recurrent, like 6 or more a year, then you would want to treat with acyclovir, and it's best if you start in the first 3 days of symptoms. Herpetic whitlow, those, if you use acyclovir, or you can use topical, those usually resolve pretty well. If they get a secondary bacterial infection, it's usually going to be staph, and so you would treat it the same way that you treat other skin staph infections, mupirocin, ointment if possible, and then if it's more widespread or it's not responding, you could do oral antibiotics. And then oral anesthetics for comfort, used with caution in children because these have Benadryl in them. So they can use either Benadryl alone or combined with aluminum hydroxide or magnesium hydroxide as a 1-to-1 rinse. A lot of pharmacies will carry these as magic mouthwash. And so some places you have to order like each of the ingredients, like when you order it. But a lot of, especially local pharmacies, like not Walgreens, but local pharmacies, you can order magic mouthwash and they'll know what you're talking about. But in the little kids, it makes me nervous because of the Benadryl, but in the older kids, if they can swish and spit it out, then it can be helpful to numb the inside of their mouth. But it's viscous lidocaine 2%, and then it's got either just Benadryl with it or Benadryl and usually magnesium hydroxide is what they put in it. If it's a newborn, if they're immunosuppressed, they have infected atopic dermatitis or lesions in their eyes and around their eyes, you want to send them to the appropriate provider. So if it's a newborn, they need to go to the hospital and be worked up. But like if it's around the eyes, you would send them to ophthalmology. But you want to get them checked out. Newborns, if you suspect HSV lesions on a newborn, that is really important to have them evaluated because it can get in their, they can like inhale it, and it can get in their CNS really easily. So they can get like herpes meningitis and things like that, and the outcome is not good. Supportive care such as antipyretics, analgesics, hydration, good oral hygiene, and then they should stay home during the initial course, and if they can't control their secretions. So most like kids don't really need to stay home from school for this, but if they're in daycare and they've got a mouthful of lesions and they're drooling everywhere, they should stay home because they're going to spread it. Cool compresses and lubricants can help. It is important to just know that it is contagious, and so we tell people that. Most people have this. It's a large number. I can't remember the exact statistic, but it's like more than 80% of people have this by age 2. So it's very common. But keeping them home if they're drooling a lot and they have lesions, and then washing hands well, trying to keep things out of their mouths, all of that can help. A 4-year-old child has clusters of small, clear, tense vesicles with an erythematous base on one side of the mouth along the vermilion border, which are causing discomfort and difficulty eating. What will the primary care P&P recommend as treatment? Oral acyclovir, topical Benadryl and magnesium hydroxide, topical acyclovir, or mupirocin ointment.
I'm gonna take a wild guess and say between A and B.
I would have picked A. I was trying to be careful about that topical.
Yeah,
Oh,
so
I didn't even see the topical.
well, that's what, so you are using it, even though it's, so you can use topical Benadryl, but usually how it comes is like they'll mix the liquid Benadryl with magnesium hydroxide, and then you'll just apply it with like a Q-tip or something. If it's on the skin, but inside the mouth, you just swish it and spit it out. But it is technically topical because they're not swallowing it. And it's coating the outside and treating it that way. So it is considered topical. So that is correct. Okay, herpes zoster, shingles. I am going to go through this quick because we don't see this very often at all, but you just do need to be aware of this. The biggest thing is that it is varicella virus, so which is why we don't see a lot of this anymore because we vaccinate against it. However, we all know the vaccine situation right now, so we will probably start seeing a little bit more of this. But they get clusters, so these lesions are clustered. They have an erythematous base. They start off as macules and papules and progress to vesicles. So the description is very similar to varicella because it's a varicella virus. They develop over a few days. They last 7 to 10 days, but they follow the dermatomes. So of the second cervical to lumbar nerves and the fifth to seventh cranial nerves. So they follow nerve patterns. They're not just going to be randomly widespread. They follow very clear dermatome patterns. They are very uncomfortable. They burn, they sting, they like even clothing touching them, air, like wind, even blowing will usually hurt really bad. And they usually have a tingling that precedes the eruption. Again, we don't see this very often at all in kids. Like maybe once every few years, if that. But it is very itchy and very painful. So this is that you can see where they're grouped and they follow those dermatome patterns. They're not just like grouped in a cluster. They they follow those dermatomes, but that's how it would be described to you in an exam question as dermatome patterns. So if it is near the eyes, forehead, nose, anywhere like really on the face, but especially around the eyes, they need to see ophthalmology. They need to go to ENT if it is around their ears because they can get hearing damage from this. Antihistamines for itching, analgesics for discomfort. You don't want to use salicylates like aspirin, things like that. Remember Ray's syndrome. Antiviral medications are not recommended if they're otherwise healthy. But if they meet these at-risk conditions, then you can give them acyclovir or valcyclovir. But kind of like varicella, usually we just let it run its course and observe for secondary infections. New vesicles will appear for up to 1 week, but they'll take 2 to 3 weeks to resolve. So they shouldn't be getting new. Typically, after about 1 week, they're not getting new lesions, but the ones that they do have are going to take a couple weeks to go away completely. They can do Burroughs solution, compresses, soothing baths, ointments, like non-medicated, like Aquaphor, Vaseline to moisturize. Calamine lotion is a big one that people will talk about with varicella and shingles, and people like it. I feel like, as a kid, when everybody was getting chickenpox and like we all had chickenpox parties and stuff, everybody used calamine lotion. But now, I mean, it doesn't work any better than anything else. So if they just really want to do it, they can. But they can also, just use Aquaphor. It is contagious until all lesions are crusted. So this is one where, similar to varicella, you'll probably see lesions in various stages of healing. And all of anything pustular or vesicular needs to be crusted. Molluscum, super common. Have you guys seen this already in clinical? Yeah, lots of molluscum out there. They may know that they've been exposed to it. Usually they don't. But it is very common. Sometimes they're itchy, sometimes they're not. A lot of times they don't have any symptoms other than just the lesions themselves, but they start as really small, smooth, dome shaped. They're usually flesh colored, but they can be white, discrete papules. The middle, they have like a cheesy core and it can become umbilicated, but a lot of times you can't see that. They literally just look like flesh colored papules on their skin. And they can really be anywhere on the body. You do want, so they can auto inoculate. So we want to keep them from scratching these. If we can keep them localized, they usually go away on their own and don't spread, but they can show up in different places. And like they might start on the hand and then go away from there and show up on the abdomen or whatever. That's normal for these. But when they scratch them and they break open those lesions, and especially if there's any type of core in it, that's how it will spread to other areas pretty quickly. So we really want to encourage them to not scratch. So it is possible, especially in young kids, to spread it to like the genital area if they're scratching. However, particularly in infants and toddlers, if they have molluscum in their genital area, that should be a red flag for abuse. Because generally speaking, we don't see this in the genital area. It can happen. But if you see it there, I would ask more questions for sure. It can be one lesion, it can be many lesions. And it can be more severe if they have compromised skin. So like immunosuppression or eczema, something like that. If they have HIV or AIDS, they will have a lot. So like If you see, even if they haven't been diagnosed with those conditions, if you see someone with like hundreds of them, you definitely want to think about HIV or AIDS, that they just don't know that they have. But this is what it looks like. So the top picture, those are clearly umbilicated. They don't always look like that. The bottom picture is more commonly how they look. They look flesh colored. So whatever that person's normal skin tone is usually the color of the lesions. So this is a really frustrating. This is an easy one to diagnose, and like you don't really have to do anything about it other than educate. But it's frustrating because people want a fix and there really isn't one. And this lasts for like 6 months to 2 years. It can take up to 4 years to go away completely, but it goes away on its own. But it's again, it's an easy diagnosis, but I don't love seeing it because people get upset that it's going to take so long to go away. Um, if it's spreading like quickly, or it's like a lot on the face, places like that, you can send them to dermatology, and these are some of the treatment options that they can do. Sometimes it works, sometimes it doesn't. But dermatology will try things sometimes. But a lot of times, even we send them to them and they say to just wait it out. Warts, this is from HPV. They can really be anywhere on the body. We commonly see them on hands and feet. Common warts are definitely the most common, and they're those elevated flesh-colored papules with irregular surfaces. Flat warts are on the face, neck, and extremities. Plantar warts are on the weight-bearing surfaces of the feet, and they grow inward. The other ones grow outward. Plantar warts grow inward. Um, so it becomes painful for them to walk. So from the outside, it doesn't look like it's getting worse, but they grow inward. So it's getting larger and deeper into the tissue. So they become more and more painful to walk on. And then genital warts look like kind of like cauliflower, which sounds disgusting. Common warts, that's, usually what they look like. A lot of times we do see them on the hands. Flat warts on the right, plantar warts, and then
Could you not
genital.
mistake those flat warts for almost like moles?
Yeah, yeah, you definitely can. And so if well, around the eyes like this, I would certainly send a dermatology, but moles will last. So if it's spread, moles won't spread. So if it's spreading, it's likely, I mean, you can get more than one mole, but if it's spreading, especially like in a localized area, it's probably flatwarts. Um, there's really not like a single effective treatment for warts, and they usually do get more of them. They usually don't resolve with a single treatment. So if they don't have any symptoms and they just have like a wart on their finger, usually we do nothing. We just give reassurance that it will go away. Because we don't want to do anything that's going to be harmful or scarring, and a lot of the treatments can damage nail beds. So that's a lot of times we see them around the nails, and so the risks outweigh the benefits of trying to treat that. Um, Genital warts in young children or in adolescents who are not sexually active is another one that you want to, that should be suspicious of a sexual abuse. Again, can they auto inoculate from another part on the body? Yes, but usually that's not the case. Um, and then we have them follow up just to make sure they're not getting infected and things like that. You can do you can treat them. So you can do treatment in the clinic. The problem is any of the topical treatments, you have to get that outer layer off, and most of the time they're pretty calloused, especially if they're on their hands. And so you have to like file with like a nail file, like file the surface off of it before you can do like cryotherapy, for instance. And it burns and it usually doesn't do anything. So it's like a lot of work, a lot of trauma for them because you're sitting there for 10 minutes like filing their wart and it hurts. Sometimes they bleed. So usually if it's really bothering them, even aesthetically, or they have multiple, we'll just send them to dermatology. They sometimes will do injections into them to get rid of them faster, but usually they just watch them as well. Lice, pediculosis, head lice, body lice, pubic lice. Usually they've been exposed. A lot of times they know about it. It's a lot of times from school or a family member, but it looks like dandruff. However, it does not pull off the hair shaft like dandruff will. Very itchy. They're often scratching, a lot of scalp irritation. And then especially if it's like if they've got a pretty good infestation, they'll feel the crawling in their scalp. So for head lice, you can see the lice and the nits. The nits are usually laid within 2 millimeters of the scalp. And so they lay the nits pretty close to the scalp. And as the hair grows, the nits and empty shells are found farther from the scalp. So if they have nits like far out on their hair, they've had this for a long time. Because they lay, so if they have eggs laid, so if you see nits like close to the scalp as well as grown out, this has been a chronic issue because it's stuck on there and they don't lay them further out. So that it's been on there long enough for the hair to grow out. And they usually will fall off, like they're non-viable when they're further out. Care, you want to make sure that because we don't want to overdiagnose this and overtreat it, and for a lot of reasons, but so you do want to make sure that it's not like dandruff, like epithelial cells, but usually you can tell it doesn't pull off the hair shaft easily. Commonly, we'll see at the back of the head, nape of the neck, behind the ears. They can have like little bites too with this, so sometimes they'll have like little red papular lesions. Eyelashes can be involved, and then a lot of scalp irritation. Body lice, they'll usually have excoriation with macules or papules, and they can get secondary infections as well. But this is one where like the belt line, the collar, underwear areas, these are common sites anywhere where there's like pressure on the skin on a regular basis, from clothing and things like that. And then you can see on body lice where the louse extracted the blood, and it'll look like a gray blue color. And they may have lymphadenopathy. And then pubic lice, usually you'll see both live lice and nits, just like on the head, but they look similar to the other two. You can have the small bluish macules and papules, and they can also have eyelashes involved with this too. So when you see live lice and viable nits, so closer to that hair shaft, we recommend treating. The recommendation, if there is no evidence of nits that are viable, so closer to the hair shaft, and there's no live lice, and they just have nits that are further out, they probably just haven't fallen off, but they're not viable. If they're not laying new nits closer to the scalp, you don't need to treat them. Just keep an eye on it, because it can stay on there for several months. But treatment failure is common. Like more times than not, it's not going away, especially the first time. There's a lot of drug resistance now, super lice. It's crazy. There are some treatment centers though that, so if you go through the pediculicides and it's just not clearing up, or it's just staying in the house, staying in the family, there are some other treatments, and most insurances don't cover them. Medicaid certainly doesn't, but they do like vacuum treatments. And there's one, I know of one in Cabot for sure. I'm sure there's more now. But they do, and they guarantee it. So it's not cheap. I think it's like $250, but so a lot of our patients can't do it, but they guarantee it. So if it does come back, they'll continue to do it as long as they need to get rid of the lice. So they do guarantee that they get rid of it. It works well, but it is expensive. But treatment is permethrin. So pediculicides, usually permethrin, is first line treatment. They are toxic, so want to make sure we educate how to use them. We don't want them to then turn around and wash their hair right after they do the permethrin. So we want to make sure that they apply it to damp hair, not like soaking wet, but not dry. And then they need to wait a couple days to wash their hair. You'll see it prescribed where like can reapply in 7 to 10 days if needed. I always put reapply in 7 days just because the chances of it getting gone the first time are pretty slim, or of them cleaning things properly afterwards are pretty slim. So initially, we do the permethrin 1% rinse. They can get over the counter or you can prescribe it. And it can be used in infants 2 months and older. They should shampoo their hair, towel dry it, then put the permethrin on for 10 minutes and then rinse it off. And then again, wait a couple days to wash their hair. Reapplication is recommended. You can also do spinosad. That's prescription strength. And it's in patients 6 months or older. It does generally work better. Insurance can be an issue with this. Most of them are covering it now, but not always. And so I just like to tell people you may end up having to pay for it. And if you do and you can't, it's not something you can do, we can do permethrin. But this one is applied to dry hair and left on for 10 minutes and then rinsed. Um, a lot of times you'll see people now, especially if they're dealing with this chronically, stop doing pediculicides and just do the manual removal. They need to make sure they're using a specific comb though. Like they need to use the knit comb. A regular comb is not going to pull the knits off. So they need to make sure they're using the right comb. Um, examining the hair really well to make sure they get it all out. But the combing generally does work well.
Hey, Dr. Kelly, I know I'm fixing to age myself on this one. Now my daughter actually came into contact with it when she was little, and that was horrifying, and we got through it. But I know when I was in school, they used to line you up and have a knitting needle with some alcohol, and they were doing lice checks. I don't know that they do that anymore.
They don't. Yeah, they did do that. They did that until probably 10 years ago. AAP does not recommend that anymore. They also don't recommend prophylactic treatment. So only if they have signs of an infestation should they be treated. We used to treat like everybody in the house. But for lice, we don't treat everybody anymore. And they can go to school. So there's no stay home for 24 hours. The AAP recommendation is to go to school because of the resistance and the recurrence. Some of these kids were out of school for 6 months because they just kept lice. So it is a big topic of debate. You will get parents 1000% that are angry about this because they, know that there's kids at school with head lice, and they usually when tell them their kid has lice and then that they can go to school, that's when they're like, wait a second. So they got this because somebody else didn't stay home. And I mean, I get it. It's frustrating. But that is what's recommended. So we don't give school notes for lice anymore. And yeah, I mean, rosemary is one thing that they can do to help prevent it. And I think that's on. So I'm getting ahead of myself. They need to wash everything in hot water and then dry on a hot cycle. Um, and iron or dry clean things that can be, if it can't be washed, like stuffed animals and things like that, they should be bagged up in plastic bags for 2 weeks, tied up tight so that it suffocates any lice that are on them. Brushes, combs, hair accessories, all that. If you can replace it, fantastic. If you can't, soak it in the pediculicide or rubbing alcohol, soapy water, whatever. You don't have to fumigate the house. They do make lice powders and stuff you can put in carpet and vacuum up. But they don't need to do some type of fumigation balm or anything in their house. Alternative treatments, there are different herbal and essential oils. You'll hear people put mayonnaise to try to suffocate them, or Vaseline. Tea tree oil has been known to kill them. But one thing that can help prevent them is rosemary. And so they make the Fairy Tales brand of kids shampoos and stuff that sell at Target, Walmart, all the places. They make a rosemary lice spray that helps deter lice. And even though I have a boy and his hair is short, I still twice a week spray his hair when he gets out of the bath with that rosemary spray because I'm just so paranoid. I don't want it. So I don't need you bringing it in the house. I can shave your head. I'm not shaving my head. So I'm paranoid. And his hair is so light, he is the whitest white kids. It's so blonde. It would take me a minute to see nits in his hair. So
My mom's a
people are
kindergarten teacher for 30
what?
years. I said, I was going to tell y'all, my mom's a kindergarten teacher. She has been for 30 years, and she's never once gotten lice from her class because she swears by rosemary. So keep using that stuff. And if she has an outbreak in her class, she'll do that and then wear her hair in a bun and hairspray it because they can't penetrate the hairspray, I guess. So,
Yes.
because I am terrified. I will burn this house down. Like for
Yeah, yeah, I
like, so yeah, it really works.
it doesn't go.
So
It's so hard to get
so
rid
with
of.
my daughter, she is and she was and still is a very white platinum blonde. And I'm telling you, it's hard to see because I had to, my friend said, "Oh, by the way, such and such came home with lice. You need to check Amelia." Oh, great. It was not fun.
Yeah. Yeah. And so they don't even tell them in schools anymore. Like they used to send home the letter, like there's lice in the classroom. They don't do that. So, um, yeah, if a friend tells you that's great, but usually they're just running around with it. But there is a myth. So it is commonly said, and it's not true, that African American children cannot get head lice. That's not true. It doesn't, they don't stick well to product. So anybody who puts like a lot of gel and hairspray and stuff like that in their hair are less likely to get it. Um, but and everybody can get it. But it was like that was like a thing for a long time. It was like, oh, like this is only white kids get lice and like gross. That's not true. And so then we have other kids who aren't being treated who could use medication. And they would stop itching so much and because they can get it. It's not as common because of hair products, but it can definitely.
So if you have a kiddo, like for example, if one of my kids got it, you would not treat the other kids. I'm just thinking like because my boys like share room and stuff, so I'm just curious, like
Not per guidelines.
So what I did, I didn't treat. This was Amelia's 14, so this was 12 years ago. I checked myself religiously because I was treating her. But we checked, we did the check around the house, but we laundered. Now we laundered everything, but I just maintained a check. I didn't treat.
Okay. Yeah, and I mean on a personal level, yes, I would treat everybody in my house, but no, guidelines wise, no. I would also probably keep my kid home, but
Well, and if you were ever asked about what the most important thing is, it's the combing out of the lice. It's like
yes.
the most important step is like you have to get them out. Um, I have a lot of heads in my house, and I have two girls that are prone to get. It's like if you get it, you get it, and even my son got it from his sister. So we've been through that, and it is, yeah, you treat everything and everything like that. But from a clinical standpoint, no, you're not supposed to, treat them. And I think it's probably from exposure. You know what I'm like, you're exposing them to the medication probably unnecessarily. But yeah, if that comes up and it's a question, the combing is like the most important step.
Um,
I have a
there,
question.
yeah,
Have you guys ever seen an African American with lice? Because I just knowing like growing up, like I've never
I have
like none of
literally
my family or
never
friends.
heard of it, never had it. That wasn't like a common thing even when I was in school for me to even see the other like black kids even get it, if that makes
I
sense.
have, and it was a nurse practitioner that I used to work with. It was one of her kids that she adopted, and she's white. She has no idea what to do with their hair, and they got it because she was like, I didn't think that that they could really get it. So it was pretty like they were pretty infested by the time that it was like caught. She just thought it was dandruff for a while, but she wasn't putting anything in their hair, really, and so it was very dry. So yes, like if white people are raising black kids, probably more likely, because I don't know what they're doing, but it's not common at all. But it's because of hair products, not the hair itself.
Yeah.
I thought I actually had seen it, but I remembered that was a tinea that it was so bad. They had to show, we had to bring him to the OR to stitch his eyes closed because the tinea had gotten everywhere. And so they had to, it was depressing. It was very depressing.
Yeah, and I was going to say, I think I've seen. Well, I would agree. I've seen it just a couple of times in Black American or African American kids, and it was I think for the same reason. It's just not, caring for the hair as they, would. But it's it's pretty prevalent in Hispanic children. And so I've seen a lot of mixed African American Hispanic children that, and again, their hair type varies. But I have seen head lice in that population quite a bit. But it could be for the same reason.
And it has nothing to do with hygiene.
No, no.
That is also a myth that
Oh,
I think
yeah, that was
I haven't heard it in a while, but that was a myth.
Yeah.
Yeah, when we were growing up, that was a big thing. Like Dr. Bishop was saying, like it was, it's certainly more common in white children. But that was kind of that myth when we were growing up that white children get it and it's because they're not clean.
So yeah, it's not common. It's not common in Black children, but it can happen, especially keep it on your DDs if they're being raised by white people. Because they don't know. We don't know. I don't know. I do now. But that's how it happens. But um, and then body lice, you want to make sure that you treat all the bedding and stuff too. Um, we're over time. I know we start acutely ill at noon. So if you guys want to I am gonna record. This is all gonna record, so I'm just gonna keep talking. But if you need to get off and like eat or whatever, feel free. This will be posted this afternoon. Um, they can get secondary infections. So daily to weekly checks or combing for lice should be carried out at home. Again, they don't do this at school routinely anymore. They should not be excluded from school or sent home from school. AAP discourages no-knit policies. This is funny. The school district that we live in the Morrilton School District, and there was like a big thing on the Ask Morrilton like unrated Facebook group last week. I mean, people were mad about kids being at school with lice. Um, and yeah, there's a whole thing. I didn't comment on it, but teachers did. They were like, yeah, we can't send them home anymore for it. People are upset. Um, okay, scabies. Key finding with scabies, itching at night. So unless there's like a lot of other descriptors of eczema or something like that, if they're having itching at night, that's getting progressively more intense, it is probably scabies is going to be the answer to that question. Um, and the itching usually happens before any of the other clinical signs. They don't sleep well. They may, like infants especially, maybe rubbing like their hands and feet a lot. It's just very uncomfortable. They commonly have excoriation from scratching. And this is one where like the rash itself usually doesn't look that bad, but the symptoms are much greater than what it looks like. Um, they get S-shaped burrows. So that's the other really defining thing is the S-shaped burrows. It's common in the webs of the fingers, sides of the hands, folds of the wrists, belt line. Genitalia is a common place for it. Genital lesions in general is common, but they're vesiculopustular lesions in infants and young children. And then they have like vesicular lesions in older kids and adults, but they can be more pustular in the infants and younger kids. Secondary lesions can occur, then those are more like of a red-brown color and they're nodular, so they don't have any contents within them. And they can get secondary infections easily because they're scratching these so much. Scabies nodules can persist for months. So even once the infection is cleared, the nodules themselves can persist for several months. Infants often have more than older kids. So infants will usually have a lot more lesions. And then young or older kids and adults will have a lot less. And then animal transmitted scabies isn't as common, but those burrows are absent and it's usually in other areas. So this is what it looks like, and you can see it between the fingers, on the sides of the hand, and on that abdomen, like especially the one in the center, kind of above the umbilicus, you can see where it's more like that S shape. Personally, with some of this stuff, I have a hard time seeing the patterns. Like when I'm looking at the rash, but for testing purposes, like I know what the description is, but for some of these, especially if it's widespread, it can be hard to see. Now, if they just have like a few, if it's like an adolescent and they don't have a whole lot of lesions, it's easier to see the S shape. But if it's a baby that's like covered in them, it can be harder to see those S-shaped burrows. Um, Resistance to medication with this one is not common. So it's treated similarly to head lice, but the treatment is usually effective. Usually they're if the treatment fails, it's usually not because of resistance, it's because of either they didn't apply the medication correctly or clean correctly, something like that. They can get post scabies eczema. Um, and eczema is more prone to having complicated scabies because it's already compromised skin. So you do scabicide. Permethrin 5% cream is the drug of choice for scabies on the whole body from the neck down. Really pay close attention to those areas where it's the most common. And then you could do it again in 7 days. And that's another one where I usually say do it again in 7 days. But um, that is the drug of choice. They can do antihistamines for itching, or topical corticosteroids if it's in like like a localized area just for itching short term. Antibiotics only if there's a secondary infection. Simultaneous treatment of family members, friends, school and daycare contacts is really important even if they're not symptomatic. So it's the opposite of head lice. You do want to treat close contacts to keep it from spreading and because it does respond well to treatment. And then anything more than the last 48 hours should be washed in hot water, linens, all of that kind of stuff. And then dried on hot as well. And then anything that can't be washed should be put in bags and tied up for a week, similar to head lice. Um, and then we just want to really educate on make sure that you put the cream everywhere, but feel free to put it thicker and like between the fingers and the areas where it's most common. And leave it on for 8 to 14 hours. So we put permethrin on the scalp for 10 minutes, but we put it on the body for scabies for 8 to 14 hours. So I usually tell them just put it on, put PJs on and go to bed and then rinse it off in the morning. Avoid overbathing because it'll further irritate the skin. And they need to stay home until 24 hours after they do the treatment. So it has
Kelly, I
to,
have a question about the scabies.
yeah,
Does this can this last months?
yeah. I mean, it should respond to treatment. Usually, it either is still somebody else in the house is infested and wasn't treated correctly, the medicine wasn't used correctly, or it was on surfaces like that weren't washed correctly because it responds really well. So it's usually more of
Oh,
another
okay.
factor, not a resistance.
Okay. We had a family that it was very detrimental for them. And mom shaved everyone's head, including hers.
Oh, for
And
lice.
no, 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 it was
Oh, scabies.
scabies.
Yeah.
Yes. And then she will come to the clinic with gloves and will bring the kids. I mean, and she will come every week because it will not resolve, and then we just didn't see her never again. But it was so bad.
Yeah.
Like I
Yeah.
don't know, she was doing the treatment wrong, and we could, we keep seeing her, and I mean, she repeated the treatment on her and the family over and over and over again. But then we never. I mean, we just saw her one day, and she showed up with like bald, shave,
Oh
and we
man.
asked her what happened, and I think it was just like very stressful for her because she had like 4 kids, and I think they were all being treated, and I think she didn't understand why we were treating them because not all of them had it, but we kind of had to explain to her that it was very important that they were all treated. But yeah, like she kept coming for like a long time.
Yeah. And it's in a population like that, any diagnosis like this that requires like
Yes,
multiple different things to do for it. It's not just like giving an antibiotic for 10 days. Is
yes.
more troublesome because they may or may not even understand, completely what
Okay,
we're saying.
yes. Well, thank you.
Yeah. I think you will probably have better results with things like this than like a lot gets lost in translation, like literally when we're using even a certified interpreter. I think there's just a lot that still gets lost in translation. Um, Whereas you fluently speak Spanish, so when you explain things like this to them, they
Yeah.
will really understand it better.
Yeah. 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 Definitely.
Yeah, you're going to be very beneficial to Southwest Little Rock. I mean, you
Thank
already
you. I
are.
hope so. I hope so. I hope so.
A 9-month-old infant has vesiculopustular lesions on the palms and soles, on the face and neck, and in skin folds of the extremities. The PMP notes linear and S-shaped burrow lesions on the patient's. Oh, parent. No, that's correct. Parents' hands and wrists. What is the treatment for this rash for this infant? Ivermectin, permethrin 5% cream, treatment with permethrin 5% cream for 7 days, along with ivermectin, or treat all family members except the infant with permethrin cream and ivermectin.
Treat everybody. You treat with permethrin. You treat everybody.
You do treat everybody, but you would treat the infant as well, and you wouldn't use ivermectin. So it's
Yeah, not ivermectin, right?
so it's the 5% cream to the face, neck, body, rinse off in 8 to 14 hours. Yeah.
I would not give. I have this thing about ivermectin. I guess it's a COVID thing.
Yeah. Yep. Okay, contact derm. This is caused by an irritant or an allergen of some kind. Sometimes you figure out what caused it, sometimes you don't. But there are different types. So the common types that we see are irritant contact derm and allergic. Irritant is not an allergic process. So it's skin damage because they've had exposure to an offending agent, like repeatedly, or it can be like a cumulative effect. Dry skin dermatitis is caused, from really low humidity and dry air, or using drying soaps, not moisturizing, things like that. The lip licker dermatitis, that's what I was talking about earlier. We see this a lot in the winter in kids because they like lick their lips constantly. And they'll get, some of them are pretty bad, like it looks pretty nasty, around their lips. And then phytophotodermatitis from sun exposure, following contact with plants or juices, and this can be like a blistered lesion. Allergic contact derm is seen after they've had sensitization to an allergen, and then they have a subsequent delayed like hypersensitivity response. So sometimes it's obvious, like sometimes you've been walking through the woods and rubbed against poison ivy, or it's on the umbilicus, like right where the button of their pants sits, and you can tell that it's like a nickel dermatitis or earlobes, and they're wearing earrings. So sometimes it's obvious what's causing it, and sometimes you don't ever figure it out. But where it's located, you want to just think about things like do they wear jeans a lot? Do they wear earrings? Have they been out in the woods? Things like that. Because it can be from all kinds of different things. Um, Poison ivy, poison oak, sumac, all of those things that we commonly see, like in the summertime when people are outside, it's the oils that causes the rash and that they react to. Um, and so it's not really that the rash itself is spreading, it's recurrent contact with the oil. Topical medications can cause a reaction as well. So this is why even like it seems so benign to just use, antibiotic ointments or whatever, but if they don't need it, we could potentially be causing more problems by doing it. Latex dermatitis is associated with use of products containing latex. So most places don't have latex gloves anymore, but you will still see them some places. And then other common allergens include dyes, lanolin, and preservatives in skincare products, household cleaners, soaps. Not as much now, but for sure when I was working inpatient at the hospital, my hands would be horrible just from washing, every time you're in and out of a room washing your hands. Um, so that is common. So they usually have had contact with something new or unusual, a history of any type of allergies, family history of allergies, because we know there is a genetic component to all of our allergic conditions. We want to know any of their home and routine activities, any repeated exposures that they've had to something, because especially for allergic, you have to have that sensitization. So if they have repeated exposure to something, they're more likely to have a reaction. And then the location and pattern. If it's, poison ivy is generally going to be on places that are exposed. So if they're wearing shorts, you probably won't see it on like the upper thighs, but you might see it on the lower legs if their legs were exposed to it. On physical exam, the area involvement often, again, will tell us what's causing it or at least clue us into something. And so that's usually our biggest clue. A chafed appearance with shiny, mild to severely erythematous, peeling or dry, fissured skin or red patches. With secondary scales can be seen if it's due to an irritant. So a lot of times this is like from frequent hand washing or like overwashing with fragrance soaps and things like that. In the acute stage of allergic contact derm, you can have vesicles and weeping, and it can be pruritic. And then as it becomes more chronic, you can have like that lichenification we talked about earlier, and hyperpigmentation. It can look a lot like atopic derm. This is different forms like of contact derm, how it can look differently on different skin tones, different areas. Like that bottom right is probably from that belt, like a nickel allergy, and it'll start small and then it'll spread because it's irritated. So usually the location is helpful in determining what caused it. So appropriate skin care is management, eliminating the offending agent, treating inflammation. Those are the key. So really symptomatic treatment. Avoid, if you can identify what caused it, avoid it. Burrow solution, oatmeal baths, cool compresses can all be helpful. Water and emollients applied to restore that moisture and help with that skin barrier again. But you don't want to use lanolin or petroleum-based emollients if there's inflammation because it can make it worse. Topical corticosteroids you can use 2 to 3 times a day, and that can help for a couple days. But it can take a couple weeks to heal completely, and so we don't really want them to do this every day for like 3 weeks. If they have it, so for instance, poison ivy, if it's on more than 10% of their skin surface, or it involves like extensive parts of the face, eyelids, genitals, honestly, like neck, like mouth, neck, face, that area, you can do oral corticosteroids, and then taper, because anything like head and neck, if it's swelling and reacting on the outside, we don't want the same thing happening on the inside and we can't see it. So that's where we would treat with an oral corticosteroid. But for your just like general like poison ivy on the arm, you wouldn't do that. Oral antihistamines are helpful to help with the itching and scratching. And then if it worsens, it's not responding, it's not getting better, then you would send them to dermatology. It can take a few weeks to heal, and then all of these things are really the same things we just talked about. So a child has an area of inflammation on the neck that began after wearing a hand knot woolen sweater, hand knit, that should say knit, hand knit woolen sweater. On exam, the skin appears chafed with mild erythematous patches. The lesions are non-pruritic and are not vesicular. What is an appropriate initial treatment? Topical corticosteroids 2 to 3 times daily, burrow solution, soaks and cool compresses, oral antihistamines 4 times daily, or a lanolin-based emollient.
Oral solution.
The second one.
B.
So is actually corticosteroids, because of the contact term. Lanolin based are contraindicated if there's inflammation, so we knew that.
Oh.
You did pick that one. Oral antihistamines are not indicated unless there's itching and scratching, and then burrow solution is really helpful if there's vesicular rashes, but for this where it's just like patchy and chafed and irritated, the topical corticosteroids will help the most with that. Diaper dermatitis, this one's pretty straightforward. It can be due to a lot of things. It's usually from either they can react to different diapers. So like if they change diaper brands or wipe brands or soaps, laundry detergents, anything like that, it can cause it. Prolonged contact with like not being changed frequently can cause it. And it causes that skin breakdown. Mechanical irritation from the diapers themselves. So like if they're not the right size, they're not fitting correctly. Here's the rubber pants again. The rubber pants can cause